Hello everyone, this is Mary Gregory with MAS Coding Solutions, and we are coming to you from our Medical Coding Lounge, which is our private social media platform. Look forward to you all joining us on that platform where we do coder chats, we doing education, we giving out CEUs for being a member. It's just a wonderful place to be. It's a place for us coders to gather and really speak, quite frankly, of what's on our mind. We may not be able to do that on LinkedIn. We may not be able to do that on Facebook. But guess what? We can do it on the Medical Coding Lounge. Okay. Well, we are going to continue our journey, and we're going to finish it up on coding lesions, removal, destruction, whatever the case may be. And our last video for now this cannot be the absolutely last video, because we always, in learning mode, it's always for us to go back to the basics because we tend to forget things. So we'll be doing some more on it again, but for now, I think we've done 2 on wound repair. We did 1 on destructions of lesions. And now we're going to talk about what they call Mohs or Mohs surgery, M-O-H-S. That is the micrographic surgery. This is an area that you will have on your CPC. They tend to like to ask questions on the CPC about this particular type of procedure. One of the things that okay, so these procedures, before we get into that, your CPT code for these procedures are 17311 through 17315, okay? So those are your procedures codes and CPT. Generally, you're going to use these procedure codes when your patient has some type of basal cell carcinoma, squamous cell carcinoma, maybe melanoma. This is generally 10 when people used when people have skin cancer. Okay, now, but there are some, I don't want to say benign, but it can be benign, but there are times too when you may have an uncertain behavior neoplasm, uncertain cancer. And when they say that a cancer is uncertain, what they're saying to you as coders and to me as a coder is, look, sometimes this thing will become a malignancy. It may develop into a malignancy, and sometimes it will not. So they call them uncertain behavior. So you may see this particular type of procedure being done on someone that has an uncertain behavior neoplasm, a cancer, and sometimes what they call aggressive benign neoplasm. So in order for us as coders to use this Mohs technique, surgery, the physician, the surgeon, will act in 2 capacities. They're going to act as the surgeon, and they're going to act as the pathologist. If you don't have both of those being performed by one physician, then you do not have a Mohs surgery. And you have to use a different CPT code, because that surgeon must excise the lesion, and they must study the lesion, put it, act as a pathology. They take it and put it under these little slides and little microscope, and they can determine if they got all of the cancer. That's the main thing. Or did they get all the cancers, including what's in the margins? If the margins show that the patient still has some cancer, then they will go in and they would cut off some more. Now, okay, this Mohs surgery is by body site, as defined by CPT, and it's also by the number of stages and tissue blocks. And I used to really struggle with that stage and the tissue block till I realized the first stage is when they first cut off the first piece or cut out the cancer. And the tissue blocks are the number of little pieces that they cut from that first piece to put under those slides. So we make this a whole lot more complicated than it has to be. The Mohs surgeon removes the tumor and tissue, and they map and divide the tumor specimen into pieces. That's what the tissue blocks are. They just little pieces. That's all. And so sometimes that first stage, that first piece they cut off, they can get up to 5 tissue blocks out of that. And that's when they'll determine, do I need to do more? Or do I have enough? Did I get it all? If they got it all, then I can stop at 1311, depending on my body site. Or it might be a 17313, just once again, depending on the body type. Now, you got your add-on codes. We know add-on codes can never be primary diagnosis, never can be principal. They're always dependent on somebody, on another code. They're married to another code. So each additional stage after the first stage, the 17312 is actually for people that's head, neck, hand, feet, and genital area. That's where they cut it off. Most of the time I see it on ears. Most of the time that's where we see it at. Or we might see it where a person have a melanoma in the face. So once again, they may say, you know what? We didn't get it all. This cancer is too close to the margins. So we're going to go in and we're going to cut out some more. That becomes a second stage or an additional stage. Because they took out second and third, it just said additional stage after the first stage. Once again, up to 5 tissue blocks. So if the physician feels like they're working on the face here, and they didn't get all of the cancer, it's too close to the margins, and they want to get an additional sample. They want to cut out some more, because remember, some of these cancers are very aggressive, especially melanoma, and so they want to make sure they get it all. So they'll go back and they'll excise some more tissue. So they excise more tissue, and once again, they can go up to 5 tissue blocks. So really and truly, that patient gonna have 10 blocks if you go up to additional 5. 2 stages, you're gonna have 2 pieces that was excised, cut out, and then of course you're gonna have 10 tissue blocks. But we don't think of it like that because they don't actually talk like that in the book. So, and then you have a additional add-on codes where you've gone past each additional block after the first block in the stage. So, but just the main thing you want to remember about the small surgery is that also too, what you want to remember, your repair is not included. You get the code to repair separate. A while back, someone asked me to look at some charts that they had. They was having a problem with getting this paid. They got the Mohs surgery paid, but they couldn't get the repair paid. But the insurance company was wrong because the repair is not included. So if they have to do a skin graft, that's not included. If they do a tissue transfer, that's not included. What else? Skin graft, tissue transfer, complex repair, layer repair. It doesn't even say a simple repair is included. So when you're doing this Mohs surgery, then a lot of times it can leave a big defect depending on how much tissue had to be removed. And so you may have an additional surgery of that repair. So watch out for that. So make sure if you're coding this, you're going to do the Mohs surgery, but you're also going to code your repair separately because your repair is not included in this particular CPT code like it is in the, in the excision lesion code, just an excision of a lesion. We know that a tissue transfer is included. The tissue transfer include the excision of the lesion. Now you can, and also the simple repair is included. So when you're doing an excision of a lesion and it's not a Mohs surgery, in other words, the physician is just a surgeon, he sent it off to pathology. So what's going to happen with that, if you have a repair, simple is included, your layer closure, your complex is not, your skin graft is not, but if you do a tissue transfer, then that excision of the lesion is bundled into the transfer. That is the only one that's like that. Why? You have to take that up with the AMA. They have never explained that, or maybe they explained it 10 years ago, and we just don't see the explanation and everything. So, they tell you in the book here, if a repair is performed, use separate repair, flap or graft code. If a biopsy is suspected of cancer is performed on the same day, because there was no diagnostic biopsy and frozen section with pathology, be careful with that one. You know, one of the things we have to realize is there's a difference between the CCI edits sometimes and CPT. They don't always agree. So always make sure that, because see, if you're doing this Mohs surgery, the physician is acting as a pathologist, okay? But I think what they're trying to say here, if there was no prior pathology, in other words, this patient never had this lesion removed, a study, and a diagnosis was made, that did not happen. If that surgeon that's also acting as the pathologist, they says, then that skin biopsy can be coded and frozen section biopsy with a modifier 59. So they just saying, if this patient never had a confirmation that they had this cancer, and they do a biopsy, and they send it off, you can possibly code it. But be careful with that. Be extremely careful. Because, see, to me, the physician is acting as a pathologist. And so if he's acting as a pathologist, then, okay, you did a biopsy. Well, you should be able to read that as well. What's the difference? But that's Mary Gregory interpretation. You know, I probably shouldn't be online saying that, because we know how people like to take things out of context and everything. So just be careful if you're going to code a biopsy with a Mohs surgery, because it might be that the two cannot go together. So be careful with that one. Read your CPT book. Make sure you get understanding. The CCI edits may have an edit on that says if documentation supported, then of course you can use it, but it's up to you as a coder to make sure your physician documentation support that a separate identifiable biopsy was not done previously, and that this box is okay to be coded, because once again the surgeon is acting as a pathologist. Okay, well, that's going to end our presentation for today. Once again, look forward to talking to you in the future. And don't forget to follow me on Facebook, LinkedIn, TikTok, and go to our website, www.mascodingsolution. If you want to learn more about the Medical Coding Lounge, go to www.himcodingacademy.com. Love you.